morning, good afternoon, good evening. It's a pleasure to host this latest session in our series with keynotes from all over the world as part of the Hamlyn Symposium. Today, I'm absolutely delighted to introduce Stefanie Speidel, who's Professor of Translational Surgery, Translational Surgical Oncology at the National Center for Tumor Diseases in Dresden, and one of the speakers of the DFG-funded Center for Tactile Internet with Human in the Loop. Now, on completion of her PhD at KIT with distinction in 2009, with a research topic centered around intelligent surgery, Stefanie remained at KIT working on computer-aided surgery for a couple of years more before moving to Dresden. Her current research interests include image and robot-guided surgery, soft tissue navigation, sensor-based surgical training, and intraoperative workflow analysis based on various sensor signals. She's also authored and co-authored, not surprisingly, over 100 publications and regularly organizes workshops and challenges, including the rather famous Endoscopic Vision Challenge at MICAI, where she also serves in various roles or has served in various roles over the years. I'm absolutely delighted to have her here with us today, and I look forward to her talk, which is entitled AI-Assisted Surgery, Perspective and Challenges. Thank you, Stefanie. Over to you. Would you like to share your screen? And we look forward to it.
Yeah, thanks a lot for the kind introduction and the invitation. I'm very delighted to speak today and give a presentation about AI-assisted surgery. So before I want to introduce the National Center for Tumor Diseases in Dresden, and I want to take you on a virtual tour. So the center is directly located on the University Clinical Campus. You can see here the new building, which was opened last year in September. And it combines patient therapy and research under one roof. So, and what is exceptional about the center is that we have an experimental OR with different devices, also robotic devices, as well as imaging platforms only dedicated to research purposes. And we are closely collaborating with the surgical departments on the campus, and my group has a computer science background. So myself, I'm a computer scientist. I have an interdisciplinary group, including also surgeons, and we work on computer and robotic assisted surgery. Before I'll introduce some of our research topics, I will start with some numbers that you might not be aware of. So according to a recent Lancet comment, postoperative complications are amongst the leading causes of death worldwide. And this was also a bit surprising to me. And so the research question that arises based on that is, how can we take computer and robotic assisted surgery to the next level, for example, by using cognitive assistance functions? So we want to provide the right information at the right time and bridging the gap between robotics and data science. So my research is centered mostly on intraoperative assistance in a so-called sensor operating room. So we have different devices. We analyze the sensor data in real time to provide an assistance depending on the surgical context. And this leads me to the topic of surgical data science within the operating room of the future. So, I mean, I guess you all know surgical skills are, include different kinds of skills. So it's not only about like the manual skills, but it's also about situation awareness. It's not only the surgeon, it's a whole team that's in the OR. It's about decision making and leadership. And the question here is, how can we quantify experience? Because it's not surprisingly that experience is the key to a successful outcome. So there are several studies that show this. For example, here a famous study that correlates the mortality for two complicated procedures, esophagectomy and pancreatic resection. And if a center is performing this kind of surgery on a regularly basis, the outcome is better. And if we want to quantify such experience, it's that there are several questions we have to ask us and to bring it to the machines. And this leads me to the term surgical data science. So the objective is to improve the quality of healthcare by capturing, organizing, analyzing, and modeling of data. So that there is an initiative that was founded 2016. I'm one of the co-chairs, and we meet regularly within workshops and try to define roadmaps and to advance the field. So, I mean, you all know with the recent advances in artificial intelligence, we need lots of data. And so data is the new oil. I guess you have all seen such slides in different presentations. And if we take a closer look in our research scenario, we acquire data within an operating room. So this means we see the operating room as a sensor-enhanced environment, which includes different devices, different imaging devices, for example, tracking data, also data from robots, kinematic data, for example. So there is a multitude of available data which we try to analyze in real time and to provide the right assistance at the right time. I already introduced this concept at the beginning. And I want to focus now on different topics within AI-assisted surgery we are working on, um, and give you some examples in this field, starting from data generation, which is a huge challenge in our domain, since we don't have such large data sources which are annotated compared to other fields where we have the AI revolution. Then this data needs to be analyzed depending on the clinical context. Then we want to provide a context-aware assistance. That means we need to analyze the workflow of the surgery to know what's happening and which assistance is needed depending on the surgical phase. And in the end, I also want to introduce surgical training, because all these methods I'm presenting can also be applied to training scenarios. And I will start now with the field of data generation. So this right now is one of the major bottlenecks in using deep learning methods for surgery or for surgical applications, because these methods require sufficient data sources. And we all know that we cannot only process the raw data, but we need the data to be annotated. And usually you need clinical experts for annotating it. So we thought about using simulation, as you can see here on top in the video, where we exactly know the annotations in the video data. So we know where the organs are, where the instruments are, and we don't need experts to annotate it. But up to now, data which was generated by means of simulation doesn't look realistic. But recent advances in unpaired image-to-image translation make it possible to generate realistic synthetic data. So we used a generative adversarial network, which makes it possible even if the data is unpaired. So we have no direct mapping between one domain, the simulation domain, and the laparoscopic domain. And if we incorporate an additional multimodal image-to-image translation, it enables us to control the style. So we can utilize this to increase the diversity in the final data set. So data encode is available. It's a huge data set, so you can see it here. We have different styles and over 100,000 images. We provide the segmentation mask, also the depth mask if you want to do stereo reconstruction, for examples, and so on. So this can be used for training machine learning methods, also for pre-training the networks, for example. And right now we extended it to video. So we do not only generate still images, but we are also able to generate videos. But this is an ongoing work, and right now I could not present any results so far. So the second topic I want to talk about is data analysis, and I want to show you an example in the context of soft tissue registration. So here the challenge is that we have pre-operative patient data. For example, here you can see an example for liver surgery. In yellow, you can see here the tumor, a 3D model, which was generated based on a CT data set. And in the intraoperative scene, it looks like that. You have the laparoscopic view, and usually the surgeon creates a mental model and projects it to the intraoperative scene. But here, we want to provide an augmented reality visualization and show the hidden risk and target structure. This is not a new concept, but it's very challenging since the liver deforms due to breathing, instrument interaction, the pneumoperitoneum, and so on. So as you can see here, this is the intraoperative scene. And if we want to use computer vision, for example, the data is very noisy. We have only sparse correspondences. Then we have unknown boundary conditions. So we don't know exactly how the liver deforms. And up to now, a lot of approaches use the finite element method, which works quite well. But it's difficult to parameterize and to parallelize. If you want to use it in an intraoperative scenario, your methods have to be really fast. And it's also difficult if you use it to deal with unknown boundary conditions, because we have very sparse literature about that. So we thought about maybe we can learn how the tissue deforms and how to match surfaces. And we came up with a data-driven biomechanical model. And the idea here is that we use a convolutional neural network that solves the registration task. So here you can see in gray is the pre-operative model we generated based on the CT images, and we get the intraoperative surface based on the stereo laparoscope, for example, like the Da Vinci stereo laparoscope. And then the task is to register these surfaces, the surface with the 3D model. And we input only the geometry in our network. It's a volume to surface registration network, and the output is the displacement field. And we can then use this displacement field to register both modalities. And important to know is that it works directly on the geometry. So we don't need to solve the correspondence problem between the intraoperative and the preoperative data sources. And it trains on random simulations. So like the data generation topic I showed before, here we also use completely synthetic simulations of organ-like meshes, and it adapts to any new patient geometry. And this is something that speeds up the learning of deformations by using convolutional neural network. So the synthetic training data was generated using a standard simulation framework using finite element models. So we generated random meshes and simulated the deformations, also the boundary conditions. Then we extracted a partial surface, which serves as the intraoperative surface we generate from based on the laparoscope images. And then we pass this data to our network, where we encode the geometry as a signed distance field. And the displacement field is also extracted. So the distance fields are the inputs to our network, and the displacement field is the output. And we do this for 80,000 meshes, and this is our training data for the volume to surface registration network. So we did several experiments starting with in silico data, and we found out that we need at least 20% of the surface to be visible, so that the registration works. If it's less than 20%, the registration fails. But there are also cases where the registration field fails because the deformation is too large. So if we have, as you can see here, a quite large deformation, you can see here that the network is not successful in solving the registration tasks. We did also in human tests using CT data, breathing motion, and we could reduce the average displacement error from 21 millimeters to 5 millimeters. And we also did qualitative tests with laparoscopic data, because it's very difficult to acquire the ground truth. And here we saw that in general it also works. So right now we are close to translating it into the OR to do the first pilot studies on patients. And yeah, we will see how the results are, but right now it looks quite promising. And because we use a CNN, it's quite fast compared to standard finite element methods. So let me just briefly show you the intraoperative model, which is also part of the registration pipeline. And here we use the stereoendoscope, where we can reconstruct the 3D scene. Then we also use a SLAM based method, simultaneous localization and mapping, because we don't know the exact position of the camera, and we localize it within the 3D map we created. And this is part of our registration pipeline. You can see it here again. Left, it's intraoperative patient data, right, it's phantom data. And as I already mentioned, we are close to testing it directly in the OR in an intraoperative scenario. So the next topic I want to highlight a bit more is context awareness. And as I already said, we want to provide the right information at the right time. And therefore, the system needs to know what's happening, in which surgical phase are we right now, what is the assistance need depending on the phase, and so on. And here you can see an example for the remaining time prediction. So the system is able to detect the actual phase of the surgery and to predict the remaining time. So this is, for example, important regarding OR workflow management. And here we use a temporal analysis via a recurrent neural network, where we use the video and image features of the video, but also different device signals we capture in the OR. For example, the status of the insufflator and so on. And So the vision here is not only to predict the remaining time, but to predict complications. But therefore, we need much more data, which is also representative for the task, because complications are not happening so often, so that we can learn when a complication happens. So this is, yeah, a challenge we have to face right now. Another example regarding context awareness I want to give is the anticipation of different tasks. So for example, or events. Here we anticipate the usage of instruments. And we formulated a joint regression and classification task. So we want to predict the time until the occurrence of a specific instrument and whether or not an instrument will appear within a defined horizon. And we used a Bayesian deep learning framework to account also for the uncertainty uh, that is associated with future events. And we showed that we can identify trigger events regarding the usage of instruments. So in this example, the uncertainty decreases when the clipper is present, which is a trigger event that scissor will be used in the near future. And that we can predict the usage and incorporate the uncertainty regarding these events. So here you can see a demonstrator in our experimental OR that incorporates different yeah, modules I showed you recently. For example, we mounted a laparoscope on a robot arm, and it's depending on the surgical phase and on the actions that the surgeon performs, it adapts directly to the view that is appropriate for the phase. So we learned this using training data or demonstrations of different surgeons. And so the last topic I want to highlight a bit more is surgical training, because all the methods I showed you right now can also be applied to surgical training. And the idea here is to use a sensor-based surgical training system. So here you can see a standard box trainer that is used in the minimally invasive courses, for example, in Dresden. And we enhance this box trainer using different sensors. So for example, we can acquire the trajectory of the instruments, the depth images, and also the video. And we also started to enhance it using haptic sensors. And the idea here is to analyze the performance of beginners and to compare it with expert performances in order to enhance the learning curve and to provide feedback during the training task. For example, feedback by showing the trajectory that an expert would perform, and so on. So there are different kinds of feedbacks one can give. So here you can see the typical task, which here is a pick and place operation. And we use different computer vision methods to analyze the scene and then to classify how good is the performance. So on a scale from 1, which is poor, to 5, which is very good. So there are standard metrics which can be used to grade the performance in such training scenarios. And we collected a huge data set so far, which will be published soon. But regarding the skill assessment, I want to show you a method where we use the Jigsaw data set, which is the most famous data set right now for gesture and skill assessment. And we wanted to use only the video data to grade the performance and to predict the skill level in the class. So we used a 3D CNN, but the problem is a 3D CNN can only process a small number of video frames. And this is quite difficult. And so we thought, okay, can we divide the videos into smaller snippets? And so the idea here is to make smaller snippets out of the video and then to put it in the 3D CNN and to classify the performance. And then we can aggregate the different classification scores in the end and get an overall classification score for the whole video. So the question here is how to train the 3D CNN. So basically, you would put the video snippet into the 3D CNN, compare the obtained class score with the output, and then back propagate the error. But we only have one label for the whole video. We don't have a label for every snippet. And because a beginner performed a specific task doesn't mean that every snippet is performed in a bad way. We saw also that there are snippets where it could also be an expert performance. So there might be a certain overlap within expert performances. And to get around this, we extended the 3D CNN into a temporal segment network. So now we look at several video snippets, and we use a Siamese architecture to classify all of the video snippets at once. And so in the end, you can then aggregate the results, and you get then one skill label for the whole video. So I want to conclude with some remaining challenges. And there are a lot of challenges we have to face right now to bring the methods from bench to bedside. So one big challenge is related to data. So we need access to annotated data. And this is currently one of the major bottlenecks for surgical AI. And the question is, where do we get enough labeled data? Is the data representative for the task? What about bias in data? And also, what about patient protection and data security? And so I believe, for example, the lack of data can be tackled by several complementary approaches. So we have to reduce the annotation effort, for example, via active learning or crowdsourcing. We can generate synthetic data sets that look realistic, and but we can also apply methods such as self-supervised learning. Then the next challenge is related to the methods. So how can the methods deal with unlabeled or weakly labeled data? How can we ensure generalization? Because models trained on the data from one clinical site, for example, in Dresden, they may not necessarily generalize to other centers. There is a large variability we have here. And then the data we are dealing with is also quite heterogeneous. I mean, I showed a lot of examples for video analysis, but we also have other data, for example, kinematic data of robots in the OR and device data and so on. And it's not only the surgeon, it's the whole team. So how can we model the different actors in the OR and their interaction? So yeah, there are a lot of research questions here, and also regarding explainability of the methods, because if we want to use the deep learning approaches in a clinical scenario, I think we need to overcome the black box paradigm, and then methods needs to be explainable. Then I showed the sensor OR, but in general, we need to get access to the devices, and this is not an easy task. So laparoscopic video is easy to capture, but the device signals are not easy to capture. I mean, I think you all know the problem with restricted interfaces and so on. So there must be a kind of cooperation with industry partners and standards also for the different interfaces. And then in the end, the integration. So no method will be used if it's not integrated into the clinical workflow in the end. So I think context awareness is important. So to provide the right assistance at the right time, and also providing intuitive human machine interface. So at the end, I want to conclude with the vision of the OR of the future, which incorporates different sensors which are captured in the OR and can be analyzed in real time. And I hope I showed you some assistance function that are important, for example, a context-aware visualization regarding navigation information, the prediction of the remaining time or even complications, or automatic camera guidance. So these are just few examples of what could be possible. And then I want to advertise in the end the upcoming endoscopic vision challenge at MICAI this year. So we have 6 exciting sub-challenges. So if you work in the field, check it out. Lots of data is available, annotated data, and hopefully you will be able to participate. And then in the end, I want to thank my amazing group, which is actually doing the work I'm presenting here in Dresden, and also my collaboration partners and funding agencies. So this is a picture before the Corona situation, and it's an old picture, so some people are missing here, but it was not possible to have a recent one. So thanks a lot for the attention, and I'm looking forward to questions.
Wonderful. Thank you very much, Stephanie. That was amazing. That was really, really good indeed. So as our audience dreams up all the questions they've got in their brain, because I had about a million, right? I'm going to start with a few points that you left at the end, which are the open challenges, because I think whether you are a little bit more on the computer science or on the robotics side, it's absolutely the case that data is the single biggest bottleneck. And I don't even think it's only annotated data, it's just some data. So have you had any luck? So I wanted to put a prelude, which is on the medical imaging side with the community, like for example, in the MICA community, there's been quite a bit of success in trying to standardize the way you acquire certain anonymized data, CT, MR, and segmenting it and making it available. I think we have a much longer way to go on devices, right? So the majority of companies that produce devices that are used in surgery are very protective of their data. And that's the data that you would want to selflessly mine because there is an enormous amount of potential value in this data. Have you had any success in approaching one or multiple companies to grant you access to the sort of data that they have and they themselves are not sure how to deal with? Yeah, but they still won't necessarily allow you to look at it because they're worried that maybe there is something there that should be protected.
Yes, and I know what you mean. So, I mean, I showed you the sensor or R, and we are capturing not only laparoscopic video, but also device signals. And this is only possible because we have an industry cooperation with Karl Storz, who granted us the access to the device data. And this is just one example. I think you need a kind of cooperation that makes this possible. But in the end, it's also the question who owns the data. I mean, the companies I know are also looking for data. I mean, they sell the devices, but in the end, a hospital performs the surgery and might record the data. So I think the patient owns the data. But also, and if the patient gives consent to use the data, also the hospital can use it for research purposes and so on. And this has to be defined, I think, in an appropriate data governance structure.
So I was more specifically thinking, because you mentioned it, right? So if you really want to acquire an in-depth understanding of what's happening in surgery, it's not only the images and it's not only the things you can see from the outside, but some of these more complicated systems, the kinematics of a robot, the the digitization points of a transducer that is used, or the ultrasound that is used to register a brain scan. All of these things, yeah, would be very useful to have access to in an anonymized, clean fashion. But I think that's what I personally have had a real hard time trying to do, because of course, um, data is the new oil, as you said, right? And so it has an incredible amount of value, and it's not always possible to make the process selfless.
I mean, we encourage also, in the context of the endoscopic vision challenge, companies to provide data. For example, Intuitive takes part on the challenge and provides data sets. But yeah, in the end, we don't have this success like in radiology or in radiomics, for example, where they have these large annotated data sets. And I mean, it's also a challenge because we have a procedure and not like one CT data set, for example. We have a procedure that lasts several hours, which involves different devices and sensor sources, and has a large variability also depending on the surgical team. I mean, the outcome is also dependent on the performance of the whole team. And this makes this even more complicated because we need much larger data sets.
So you mentioned variability, and another burning question popped into my head, which I had made a note of, and that is that you, as well as I, have spent quite some time trying to figure out whether physical models versus closed, black boxes is the most appropriate. So FEM, so the understanding the physics behind tissue deformation is one option, and then you have got the black box solution where you're basically doing surface registration and deformation based on a whole lot of data. If you were to look 20 years down the line, which one do you think has got more mileage? And I speak because I spent 15 years with my colleague Daniele here in McKenzie trying to create a sensible model, realistic model of plastic deformation to brain tissue. And the process has been 2 steps forwards, 3 steps backwards, 1 step forward, half a step back. It's incredibly complicated. We've got a long way to go. So from where you sit, will we get to a point where we can create physics models that actually capture the reality of complex, heterogeneous, biphasic, porous, hyper viscoelastic structures, or we're just going to bypass all of that and just look at the outcome, and then the algorithms will basically figure it out in some way that we don't quite understand?
Yeah, well, it's a good question. And I mean, I spent also some years regarding biomechanical models and how to deal with the boundary conditions and so on. And I was really surprised when we tried the CNN approach, because I thought, okay, maybe it works, but but in the end, it works really well. Yeah, I was really surprised. I was not expecting such a result, but I mean, it's not that it works for every situation and in every context. And I think what we use right now is a finite element model to create the training data. And I think if you are incorporating more specific data, for example, regarding the tissue models.
The tissue models, if you look at any one paper on tissue models, the error bars are 3 times the size of the mean.
Yeah.
Right? So I want to know what the elastic modulus of brain or gray matter is anything from
it's the same for the liver. But I mean, you can use this and generate lots of training data and using different elasticity models for the different organs. And in the end, the network then has to sort it out. But the more information you give to your training data, the more accurate the registration or the data-driven registration will be. So we are trying right now to make the model we are using to generate the training data more accurate. And I mean, it's also the question if there are tumors inside the deformation changes, or if you have a cirrhotic liver, for example, it's a completely different task. But yeah, I mean, there are a lot of open research questions we are facing here right now, but I think a combination of both is a good way to use this for generating synthetic training data.
And here is another difficult question from Ricardo Moradore, who says surgical data are precious and annotation is long and must be done by experts. Indeed, it is not a matter of cats and dogs. How can we have a good enough accuracy with a small amount of data with high variability? You answer that question, I can more for you. It's an incredibly good question, but yeah.
Yeah, it's also a question I ask myself. So I don't have the solution. I mean, I think we have to tackle this using several complementary approaches. And for example, I showed the synthetic training data generation.
Yeah.
And we are also working now to generate videos, not only images, but I mean, these are small snippets. It's not the whole procedure. I don't know if this is even possible. But then I think to annotate the data, you can also use active learning, for example, which is also something we are applying, so that the expert only sees the data snippet where the method is uncertain about. So this reduces the annotation effort. And yeah, and I think also on the method side, methods such as self-supervised learning are a way to research to tackle this problem.
If I were to offer my own thinking at the moment, after having just begun to dab in the area. So when you think of dabbing, you think reflection and shearing and flipping and so on. But obviously, there's also synthetic data to augment the real scene, where you're taking aspects of the real scene, creating a simulated environment, and then using that to expand your data set. And having just begun to look at it, I am actually quietly confident that in the not too distant future, the power of those synthetic setups could really help us to reduce the number of physical data sets that then has to be segmented and tried out by expert clinicians, like Ricardo was saying. So it can be much more powerful than it is now, just based on the fact that the realism with which we can create these simulations is improving really quite fast indeed. Hansen, he asks, can you expand more on using haptic data for surgical training? What haptic information is most useful and how do you collect it? They're all difficult questions.
And actually, we are just beginning a collaboration with the mechanical engineering department within the excellence cluster. So right now, we don't have integrated any haptic sensor in the instrument, but we did some studies regarding the haptic feedback. So for example, how to give during training scenarios feedback. So we integrated a kind of pulsating ring into the instrument. So for example, if the instrument is going out of the scene, which happens often with a beginner, it pulsates and notifies the beginner that the instrument should be moved again towards the laparoscopic camera. But right now, I cannot say anything regarding the haptic instruments, because this is done by our collaboration partner and we just started.
Stefanie, I have many more questions myself, but I see we're almost out of time. And I wanted to touch upon a slightly higher level question just to finish things off, which has to do with machine learning. So clearly, it is an aspect of the field that has percolated through all of the things that you do in surgical training, in the imaging, and so on. So if you look at your end of career nirvana situation, where do you think, or what do you think machine learning will enable? And is there anything that we should be wary now about what may happen in the future? And I'm sort of suggesting here, in the lay media, there is a lot of good and a lot of misconception about what machine learning is and how it can be useful in our broad area, which is healthcare technologies. So what is your own personal opinion about what the future holds with regards to the integration of machine learning / AI in surgical technologies?
Yeah, I mean, I think all the promises that AI gives right now cannot be held in the future, because I mean, I think I think it has a lot of potential, and I think we need to bridge the gap between, you know, the mechanical devices and the data analysis part. And I think for specific tasks there will be a lot possible. So for semi-automation of knot tying, for example, or to provide the or to predict complications and so on. But I think it won't replace the surgeon in the future. And I think there are there is so much variability in surgical procedures, and the field just started. So I mean, we are trying right now to set up a multi-center study where we get data not from one center but from different centers regarding the same procedure. And this is already really difficult to acquire because also the centers are performing the procedures in a different way, and then we have the problem with bias. And not only bias regarding the patients, for example, and data representativeness. So I think the usage has to be quite specific and well defined, and then I think it has the potential to improve the
Yeah,
outcome.
see, Ricardo says, in the AI community, 95% accuracy or robustness is very good, but that basically means 1 out of 20 decisions are wrong. And so obviously from a clinical point of view, that's very likely not good enough.
Mm.
So are there any ways to robustify the decision-making process, right? And I think the answer is, these are instruments, right, that are always serving the human clinical operator. And I think as fast as you progress, yeah, the capabilities of these tools would empower clinicians to make better decisions. But I don't know whether we're going to be ever in a situation, Stefanie, where the machine will override the decision of the clinician. Any thoughts?
I don't think so, and I also think this is not what we want. In the end, I think it has a lot of potential for not so experienced surgeons. I mean, you cannot go every time you have something to a center where you are operated by the most experienced. And I think the question is, how can we quantify the expert knowledge and make it accessible to machines, and so that not so experienced operators are benefiting from it.
And it's companies and clinicians and scientists that have to sort of figure out what this new landscape looks like, because it really is very early days indeed. With that, I'd like to thank you very much, Stefanie, for taking the time to give us this wonderful talk. Remind everybody and the audience that this presentation will eventually be made available through the YouTube channel of the Hamlyn Symposium, so that those of you or those of your colleagues who have not been able to be here for the live session can see the presentation afterwards. And remind you that the whole array of future activities between now and the end of July is available at www.hamlynsymposium.org. I'd like to thanks again everyone and Stefanie for your time, and please have a wonderful rest of the day. Thank you,
Yeah,
Stefanie.
thanks for having me.
It was a
Thanks a
pleasure.
lot.
Thank you. See you.
Bye.